So now I would like to introduce you to our next speaker, Karen Peters. She is the Executive Director of Breastfeed LA, the Breastfeeding Task Force of Greater Los Angeles, and represents the West region of the State Breastfeeding Coalitions at the United States Breastfeeding Committee. Karen was the lead lactation consultant for the California Birth and Beyond Training and Quality Improvement Project and has worked with many hospitals on their journey to become baby-friendly. So we approached Karen because we knew she had experience. And she has a terrific understanding of Baby Friendly USA's expectations, processes, and supports, as well as being familiar with the issues that hospitals face with pursuing Baby Friendly designation. So Karen's going to present and facilitate 2 sessions today, one around developing and revising your Baby Friendly work plan, and the other on data collection requirements. So please join me in welcoming Karen as she presents Hiking the Mountain One Step at a Time.
Thank you, Jennifer. My credentials are that I have a master's in business, I'm a registered dietitian, and I'm a board-certified lactation consultant. So one of the things you might ask yourself, so what can you tell me? I'm a nurse, or I'm a doctor. And I want to let you know that in Los Angeles County, we have 130,000 births. 20% of them are in baby-friendly hospitals now, and my organization has had the pleasure, the joy, the honor of being the coach, the assistant. So no, I've never worked in maternity care. I have worked around maternity care and am the outside supporting coach. So that's why I come. And I leave this up for just a second to also remind you that when we go through a master's in business, we learn a lot about organizational theory and the psychology of change and quality improvement. And that was my favorite part when I was in my MBA. The finance was like, ugh. And I'm glad I had it because I can do grants management now. But organizational change is a lot of what drives me. It's my passion to help other folks. So I need to let you know that no, I don't have any significant financial disclosures. Darn it, it would be kind of fun if I had extra money, but I do work for Breastfeed LA. We are a not-for-profit. We're the coalition, breastfeeding coalition in Los Angeles County, and we do have grants and contracts that help us do this work. I don't represent Baby Friendly USA. So when I say our experience is, I'm talking from the hospital points of view. And if you have any questions at all that are of the baby-friendly nature, write to info@babyfriendlyusa.org. And every morning, Pat takes the list of the emails from the day before, Pat Kelly, and she gets the whole group together virtually, and they have a stand-up meeting while they triage the questions that come in. And they're sorted by reason designation, by the step in the Ds, or by what other need there is. So they're a great responsive organization. If you don't hear from them in 2 weeks, we nudge them again, but they really do intend to get to our concerns, all of us in the field, all the 637 plus hospitals and helper groups. So they've got a big job to do, and we're so grateful to be partnering with them. I also do not represent the Joint Commission in this afternoon's talk. I will tell you what I know about the perinatal care core measure set and share what we've learned in our hospitals. I do like to hike. So when we climb the baby-friendly mountain one step at a time, we assemble our team first. And we have milestones or markers along the way. Inyo National Forest is on the eastern side of the Sierra Nevada, and I headed up there during Labor Day weekend just a couple weeks ago. As we go along the way, sometimes storm clouds are brewing. Anybody else in the room hike? Okay, just a few. You have this metaphor is resonating here in Colorado. So storm clouds come brewing, and we see them coming, and we need to anticipate them and make ourselves safe along the way, as well as our patients, our staff, our colleagues. But without those without those storm clouds, we wouldn't have the beautiful sunsets along the way. So getting through the stormy situation to the other side of a beautiful sunset is part of what happens in Baby Friendly. So a quick story I want to tell you here is at one of our hospitals that is in the dissemination phase now. They're auditing their mothers. They're listening to their mothers, is the way Baby Friendly UK says it. We're listening to our mothers. So they have an audit questionnaire. There's one on steps 4 and 7 is rooming in and skin to skin and rooming in. So the lead lactation consultant was looking at her 10 audits, she does 10 a week, and found consistently one OB was her births were not going skin to skin. And this is someone who says, yes, I support baby friendly. Yes, I did the training. Yes, I'm in committee and speaking forward. But her mothers were sharing a different experience. So that's the storm. Oh my God, here's this person saying one thing and doing another. So the lactation consultant baby friendly coordinator went to her and brought up the issue, and the doctor said, oh no, of course my babies go skin to skin. And because of the baby friendly process, because of this process of having audits, having data, and having mothers' stories directly, Sylvia was able to say to the doctor, but this is what your mothers are saying, and Mrs. So-and-so's still in the room. If we'd like to have more conversation, let's explore this further. And the doctor did rethink it, and the beautiful sunset afterwards as her skin to skin descriptions from her mothers now have soared and are pinging at 100%. So we can go through the storm, especially armed with tools and support from one another. There are sometimes placid moments along the way where everything seems very peaceful. There are times that are unexpected joy, when the sun is glistening off the mountains, when we have the anesthesiologist at one hospital who said, nobody gets to leave this area, and my area of supervision, which is he's in charge of the mothers and babies in the delivery room, whether it's the OR or the delivery room in that hospital. He says nobody leaves until they finish skin to skin. That's it. He made himself the champion. It's not in baby-friendly 10 steps that the anesthesiologist has to do this. He's not going to be. In fact, during their survey, he was walking up and down the halls, and he was hoping the surveyors would choose him, but they didn't. They wanted their 3 OBs and 2 peds like they always take, and he was disappointed. But he was a crowning joy in the process. You have to stop and smell the flowers along the way. In baby friendly, it can be overwhelming. The shaping the path, as Marianne talked about, is so incredibly important in taking moments to celebrate, to smell the flowers. And to me, the flowers are the moms and babies and dads. To be around a couple, a family that is bonding and growing is the beautiful, beautiful time, and we need to take time to remind ourselves why we're there. Then when we get to a summit, I was going to Kearsarge Pass. It's only 11,300 feet. It's not really, really tall. I've done the 14,000 Whitney, but this was a short weekend, so that's what we did. Celebrate those moments that you're at the summits. They happen along the way as you achieve the next step, whatever it is. Redesignation for Karen and her crew next year. Designation, that bridging from step to step within the 4D. And then another reflective moment. Okay, what's next? We've achieved that. Take a moment to take the time to retreat and to allow people to think about what's next, and then make the next plan. Here we are, headed down to the car, already talking about when we're going to San Jacinto in 3 more weeks. Baby Friendly is ongoing quality improvement, continuous quality improvement. There's always the next thing. And how many people are in the NICU in this room, either nursing or medicine, anything? Okay, NICU is next for Baby Friendly. There will be 10 steps to successful breastfeeding for the NICU relatively soon. It's really an important area. Our most fragile babies deserve quality care, and there's been so much work done in the NICUs around quality improvement already. I think it's going to be just a really easy fit, so it's exciting. So let's all do the 10 steps. In your folder, you have a flyer that looks like this, and we have me, the audiovisual, up here, and we have the list. So with handy reminders, one of my staff members, Christine Gibson, stays awake at night and thinks of these things. So Christine came up with the handy reminders, because what is step 4? What is step 7? What is this stuff? This is one way to help you get your head around memorizing the 10 steps. So put your hand up like this for number 1. There's number 1. Number 1 is policy. It points the way, right? Policy points the way. It covers our butt, if you will, and we depend on policy to be evidence-based and to guide us where we need to go and help us feel firm in our practices because our policy is strong. Policy points the way. 2, put fingers like this, 1 and 1. 1 and 1 make 2, right? Staff education is an interactive process. We talk, we listen, we talk, we listen, we communicate with one another. That's what training really is education and communication. And then for step number 3, take your left hand and put it up like this, so you're looking at it on its side. 3 on its side is E for education. Okay? And prenatal education is absolutely golden. It is the way that one of the other speakers said, it's the way we have patients come in expecting skin to skin, expecting support for their choice to breastfeed. And then also one of our cute tricks I like a lot, because 55% of our mothers in California are WIC eligible. So prenatal education, take that E and put it on its side, and now it's a W because it's the provider of prenatal education of greatest source in our state and I'm sure around the nation. So skin to skin, 4 fingers like this with your right hand, put out your other arm and rub your skin. I got a jacket on, but many of you can rub your own skin with those hands. So step 4 is skin to skin and supporting breastfeeding immediately after birth. And Baby Friendly has changed that wording a bit to be more emphasis on the skin to skin portion, because we know babies will do what they need to do. If we do, get out of their way and get them skin to skin. So step 4 is skin to skin. Step 5 is kind of funny. It's hand expression, right? Press, compress, relax. Press, compress, release. Because in step 5, we're supporting breastfeeding even if mother is separated from baby or baby is separated from mother. We're showing her how to maintain lactation. Hand expression is key. All mothers in baby-friendly hospitals need to learn hand expression. Exclusive breast milk feeding. This is kind of the silliest one in here, but if you take a 1 with a thumb, 5 fingers, now we have 6, and you wrap it around, does it kind of sort of look in silhouette like a breast? Exclusive breast milk feeding. Okay, a really long nipple on my head, a short one. So that's our exclusive breast milk feeding, and we'll be talking more about documenting that when I do the talk on JACO this afternoon. Step 7 is 2 and 5 for 7. This is the mother-baby dyad, and we room them in. We keep them protected. The cuddle time that Marianne talked about, nap time, are certainly trends that I'm seeing, not just in Los Angeles County, but nationally. Hospitals are starting to take posters to A1 and talk about really how do you implement a quiet time in the afternoon and what impact that has on your breastfeeding nighttime rates. If you've done your job in the daytime to help people bond and learn when they're awake a little bit more, and then at nighttime see the benefit of that. Cue-based feeding or on-demand feeding, I'm hearing here in Colorado, that's a pretty done deal kind of thing, but I encourage you, you'll be auditing that and finding out where you really are. So to get 8, we go 4 and 4, and one of the cues that babies do is they chew on their fingers, right, to say, I'm hungry, suck or chew on their fingers. So 4 and 4 is cue-based feeding, not by the clock, not every 2 to 3 hours, but when the baby is showing signs of readiness. And then no artificial nipples is 4 and 5. It's no pacifiers. So here in Colorado especially, I'm hearing no pacifiers is a challenge that needs to be overcome. It's also supplementing without artificial nipples or avoiding artificial nipples. And then follow-up care, 10. So we got 5 and 5, and we surround the mother with continuity of care in the baby-friendly process. So hopefully this helps you remember the 10 steps a little bit more, and I'll be quizzing you later, so we'll come back to it. As Marianne has already said, the Colorado Can Do 5 are tightly related to the baby-friendly practice steps and the follow-up steps. So these are the areas where you guys have made the most improvement already and the most focus. So 130,000 births in LA. We have 57 hospitals. When we think about quality improvement and baby-friendly, we think of them synonymously. In maternity care in LA, the only numbers that have been gathered, the only data that has been collected traditionally has been patient satisfaction data, right? That's it. That's the only thing that our maternity care units really had is any kind of numbers. So collecting data on skin to skin, collecting data on rooming in, collecting data on exclusive breast milk feeding is relatively new in our community, just in the last 5 years or so. But as we then collect our baseline data and start to make improvements, we are seeing our numbers go up. We're very excited about that. Currently, we have 18% of our births in baby-friendly hospitals, and we have a wonderful 29 that are similar to you all in the baby-friendly journey, in the 4D pathway. And we have a few that are not yet pursuing it. I say yet because I think they will be shamed into coming along with everyone else. This is a list of our baby-friendly hospitals. You can see Kaiser. Yes, they actually have 11 medical centers, 13 now, 11 at this, that are baby-friendly, 13 are brand new. You can't open the door and be baby-friendly, so you have to do it a bit. And all of them in Southern California are baby-friendly. In 2007, they made a commitment to be baby-friendly by 2010. Some of these came along in December last year, so in 2012. It took them a little bit longer, but as a regional commitment, it's pretty phenomenal what a system can do. And I know some of you are part of systems, so it's one of the reasons I plant that seed. These three hospitals are our county hospitals. So, of course, they serve the poorest of the poor, the people who are in the most chaos in their world, and the most medically challenged. These are almost all our dual or triple or quadruple diagnosis people. They're pregnant and they have many other problems. And so we assisted them to become baby-friendly during a previous CDC grant called the Communities Putting Prevention to Work grant. And all of you achieved the designation. They're the one on the right in 2011. And these numbers for them to maintain their breastfeeding rates in the next year after designation makes me so proud and pleased and grateful, because it's easy to slip back if you're not paying attention. So we're really excited that they were able to maintain their exclusive breastfeeding. Harbor UCLA and LAC USC have achieved their designation in May of 2012, and they're the first hospitals in the nation to go through the 4D pathway. And that's one of the reasons I'm here, is because we were side by side, shoulder to shoulder with these two hospitals as they were pioneering with Baby Friendly. We joked, this is the LA pilot. There was also a New Jersey pilot going on, and there were some people in Connecticut who followed right after us, but we were the LA pilot, and they achieved the designation, and we were there to support them. And their exclusive breastfeeding rates show that the work that we do in policy and practice changes has outcomes, positive outcomes in breastfeeding. So if we have these hospitals achieve the designation in 5 years, our county should have 76% of our births in baby-friendly hospitals. And in particular, I think all of us around the nation think about this issue, is that we have populations that traditionally don't breastfeed at the rates that some of our other populations do, and baby-friendly improves everybody's rates. So I like to say that the rising tide raises all ships. So our African American and our US-born Latinas have very poor rates in LA County, as around the nation, and as the Caucasians and the Asians have higher rates. As the breastfeeding rates increase, everybody increases. We haven't closed that gap yet. We have more work to do, but this is using baby-friendly as a way to address healthcare disparities is a positive thing for public health to support. So you've seen the 4D pathway. You have the handout in your packet this time, and we're going to concentrate on the work plan. So that's the next part. This is the plan, that path going up to the summit along the way. Now, I don't expect you to read this slide, but I want to let you know that this logic model has been created by Baby Friendly USA. It's in the development toolkit in the work plan. After lunch, we'll have a session where you're going to work on the work plan in teams, and this logic model is one of the things that I will point out again at that time. But the exciting thing to me, I don't know who likes logic models in the room? Everybody love them. So. Okay, I was in the so-so camp, and then as I started really working with this and working with hospitals, I kept coming back and going, hey, this is in the logic model, and it's reframing it in ways that I think that other people can understand. But there is probably some data geek in your hospital or some grant writer in your hospital that likes this model. So taking some time to utilize the tools that you have from Baby Friendly USA is awesome. One of the things that Baby Friendly says that you need to do right away, the first box in the 4D pathway, is to establish a multidisciplinary committee. They call it BF committee or task force. I've heard it called all different kinds of things in hospitals. Call it whatever your team will identify with and like. In one hospital, it's the infant nutrition team. Fine, that works. What breastfeeding is, the best, infant nutrition. Others, it's the Baby Friendly Task Force. Other, it's the Baby Friendly Committee, whatever. Pick a name. Needs to be multidisciplinary. We strongly recommend, and this is our recommendation from Breastfeed LA, that you have representation from administration and all areas of nursing where the mothers and the babies are, days and nights. The comment earlier that Marianne made about the night CLE, not just night nurse, but night CLE and nurse, feeling so disappointed and angry that she wasn't included. Learn that lesson and include all areas. Physicians are our champions and our leaders, and we need to cultivate them and bring their voice to this table also, mostly so they can, well, many reasons, but one of the challenges is getting the outliers, getting the people who are late adopters to come on board. And physicians talking to physicians is a powerful tool to leverage. Your quality improvement department, this is a quality improvement project. Some hospitals and some regional systems have really amazing in-depth support and knowledge that's in quality improvement. They've applied it to other issues in the past, cardiac issues, falls. I'm not thinking of another one right now, but you all know that these life and death issues QI has been working on, and they are skills that they can bring to the table for this lower risk area of maternity care. Purchasing is essential, needs to be involved. Karen said buying formula was not a big deal for her hospital. I'll share with you more some of the stories that we've had in LA, and purchasing has been key. Sometimes as needed. If you've got it's a no big deal in your hospital, then they don't need to attend every meeting. But if it's an ongoing challenge and it hasn't been resolved yet, then they need to be involved. And lactation. The lactation doesn't drive this project. Lactation is the beneficiary of the work that goes on in quality improvement. And if lactation is driving this, if the lactation people are in charge of this, it will take longer and it may even fail. This is a nurse leadership issue. This is a hospital initiative. And then as needed, you're going to need IT when it comes to managing your electronic health records. Nutrition may need to be involved. I'm a dietitian, so we have to put nutrition on the list as needed as well. At one hospital, pharmacy turned out to be an easy fix, but it was a huge barrier because as medications were dispensed to the mothers, the pharmacist was saying, and don't use when lactating, and don't use when lactating, and it turned out the head of the pharmacy just didn't have the information. So once he came to a meeting and they handed him the Hale book and the NIH resource for LactMed, then he changed the formulary within a week. And all the information came out appropriately about risks and benefits, because the medication is still an important area to be looking at carefully. Occupational therapists know how to pace bottle feed. Nurses who've never bottle fed a baby, because they've usually just been handing a bottle to a mom, need to learn how to pace bottle feed themselves so that they can in turn teach patients. So OTs can be very helpful. If you have clinics that are associated with your hospital, or you have outpatient prenatal care and postnatal care that's tightly associated with your hospital, or even loosely, then bringing them in to be involved. Marketing can be really key. The marketing department, there's another handout that you have, helped develop this brochure that was used to educate all hospital staff members about the Baby Friendly Initiative at Harbor UCLA, and to have marketing help think about what's our internal marketing, what goes in our internal newsletter, what things can we produce that are for a whole hospital, and also for how you market to the community and to providers. So marketing can be a real key to help move this process along. Social work sometimes, one of the hospitals, when they were doing their pregnant women interviews and they really wanted to get from the high-risk OB clinic the information of what are the providers really telling you, so this is an audit tool. The social worker in that team volunteered to be the person to interview the mothers. And we said, well, that's great, but like, why do you want to do this? Breastfeeding is not officially on your agenda. What she found is when she interviewed the pregnant women in a non-threatening way about what are the practices, what has she learned about breastfeeding, whatever providers told her, then she also began to form a bond. She got their phone number because many of these patients were going to end up with babies in that NICU. This is the high-risk clinic. And then when she was trying to chase them around inpatient-wise, she had already a relationship. So you kind of never know where your team members are going to have their own motivation that brings them to the table, and they can be very helpful in getting the tasks done that need to be done. And there may be others. Anybody can think of someone or somebody in a baby-friendly hospital who's a discipline that's not represented on my slide. Yes?
The patient care techs, because they have a lot of contact with moms that are asking for formula and asking for pacifiers.
That's right. So your patient care techs or OB techs, yes. What else?
The interpreters.
The interpreters, thank you. Yes, yes, very important. And helping, I think that it helps so much for the interpreters and the nurses to develop a strong relationship, because this isn't the only issue that needs to be interpreted. Tamara?
EBS.
Yes, environmental services can be so helpful because they're often the ones who are in one of my favorite stories is all hospital training happened in this hospital on their way to baby friendly, and environmental services was included, and we are a baby friendly hospital. Mother dyad is precious, very basic information, rooming in, and if you have any problems, be sure to contact lactation. And so one of the lactation consultants was leaving, walking down the hall, and one of the environmental service women came over and got her and said, Pachula, her last name is Pachula, you have to go into room 101 right now. That mother's about to give a bottle. And she needs you. So they can definitely be very helpful. They have eyes and ears where we might not all the time. I'm sure there are others that you'll think of along the way. It's really, really smart to break into subcommittees. I have seen hospitals where all the work is done by one person. They became baby friendly. She retired. She was done. This was her crowning moment. And their breastfeeding rates went down and their practices declined. So for sustainability alone, you should have a committee, a team that's doing this. Also, it just is a hospital-wide initiative. So the ones that we found the most helpful are a group that can get working on policy right away. It's kind of, sort of, in some ways, its own section. And also in your handout is the policy from LAC-USC, one of those first two hospitals to become a 4D pathway hospital. It's very straightforward. When Baby Friendly USA saw this policy, organized by the 10 steps, a unified policy, they wrote back and said, that's one of the best policies we've ever seen. Can we put it on our new website when we get it up? Well, they haven't put it on the website yet, but we took that comment and went back to LAC and said, can we share it? Breastfeed LA. If Baby Friendly doesn't have their website together yet, don't worry, we're ready. And so they gave us permission to share this. It is not be-all, end-all. You do have to make it fit your own hospital. You don't just take this and change their name. Certainly, you need a committee to look at this policy. Other policy recommendation is from the Journal of Human Lactation. There was a model policy for the state of New Jersey that was published as well. So policy is its own subcommittee. Education, both staff education and patient education and provider education, makes a very nice subcommittee of people who get excited about education, because I love that one too. Practice, the practices that we're actually doing. We're examining the practices we have right now, auditing for baseline, looking at what policy changes we've made, and then implementing those practice changes. And I'll discuss one practice change in particular and use it as a case study for you. And then the community, steps 3 and step 10. I'm sorry, I should have put that slide up. Steps 3 and steps 10 are really our community piece. Prenatal education, how moms come to us at the hospital, and then discharge follow-up care afterwards. So continuity of care, or the community committee is another group. And then purchasing. And being in compliant with the WHO code. So we joke that there are really 11 steps in Baby Friendly, not just 10. I don't have a way to do 11, so we don't, but it is the WHO code. And not just purchasing formula, but also ensuring that our messaging is in alignment with the WHO code, and that our posters are posted in all the right places. Like Karen was saying, they need to be in a bunch of places. Those are the main parts of that one. So how do you run your own committee? Some of you have just entered development and may not have yet started your committee. So one is identifying the players, and the second is looking into your development toolkit from Baby Friendly USA. They have a wonderful set of tools. I would print them all out and put them in a binder. Yes, and then distribute copies of them to your committees at different times, different pieces. This meeting planner is an excellent meeting planner. Some of you have great experience with running meetings and know the rules of things like start on time, finish on time, be consistent, take minutes, post action items, follow up with people. You know, those are the basics of meeting management. But for some people, especially a lot of clinicians, that isn't a skill set that really developed. And if a clinician's going to be in charge of this or part of the group, then utilizing this planner is an excellent idea because it really is basic, but at the same time helps you remember to dot all the I's and cross all the T's about running an efficient, effective meeting. One of our hospitals, there was a NICU nurse who was promoted to NICU manager, and no, it wasn't you, Tamara, but another one, the same thing happened as to her, promoted to NICU manager, and she was also given the title of Baby Friendly Coordinator all at once. And she had, yeah, why not? Doesn't that make sense? Yeah. And she has us as a group coaching her, and so as we talked with her about where her skills were and where her skills were lacking, this tool then made her, literally, she ran the best baby-friendly committee meeting that we've ever seen. It was just astounding at the work that she was able to do by being a smart woman and reading the tool and utilizing it. How often should you meet? We have found that the teams that are most successful have kind of a big group meeting and small group meetings. Then the big group reconvenes. In some hospitals, most hospitals, monthly has been the routine that works. Partly because you get it on your calendar, it's the second Thursday at 1 o'clock, and it becomes a routine that just happens. And if you miss 1 month, it's boom, it's right there the next month. Some of our hospitals have insisted on having a quarterly model. Yeah, Karen's shaking her head. I don't see it as successful. They kind of have to push up against it, and their subcommittees end up kind of spinning their wheels some of the time. So this is the model that we've found that works. And Karen, for you all, it's somewhat similar. You have council meetings, so that things are another layer of meetings in there as well.
And we're beyond.
And you're beyond getting.
Well, everything happens now in practice and council.
And practice and council now.
Practice and quality. So.
Yes, and that's really awesome that it then becomes just part of the system of how quality and practice is managed in your hospital. But on the journey, it's really important when I'm hiking to stop and take frequent rest breaks and drink my water. I think these weekly meetings are somewhat like that, a time to refuel with each other, reconfigure what have we done, what have we not done, what are our joys, what are our challenges. So we recommend that you prioritize the practice changes. And the first practice change that we recommend that you get involved in is prenatal education. It makes the nurse's job in the hospital so much easier. I know we joked earlier about nurses' jobs. It's not our job to make nurses' jobs easier, but it is something we have to think about, is what are we laying on top of already busy, overscheduled nurses, overwhelmed nurses. So prenatal education is key. We have found that the clinics and the practices that are doing some breastfeeding education are missing the key baby-friendly points, and that the materials that are available from the Department of Health and Human Services is the Your Guide to Breastfeeding. I haven't reviewed Colorado materials, but I'm sure there are materials that are local or specific here. You may have materials that you've been giving your patients for years and years and years, either when they come to your breastfeeding class or your childbirth education class or your tour. Those are all opportunities to do prenatal education, as well as in clinics and in prenatal care providers' office settings. But what we found they're missing is the importance of skin-to-skin, the importance of exclusive breastfeeding for 6 months, and the importance of rooming in. I knew there were 3. And the importance of rooming in. And so when we've been auditing mothers in the community, we find they don't have these things, even though they went to a breastfeeding class, even though they went to a Kaiser breastfeeding class or whichever. So Kaiser really struggled with prenatal education, and they had to come at it in many different ways. So it was really kind of exciting to watch them stumble a little, but then pick it up and do it better. So provider talking points is part of a toolkit that we've produced. I'm not selling you a toolkit, but it's just one of the things that we think is essential. This particular guide covers those points that we said are lacking in our prenatal education audits. And this tool that we use is not another piece of paper to hand to mothers. It's a tool that's something like utilized in clinic flow the way a menu is utilized in a restaurant. So you know, you're handed the menu at the beginning of your time in the restaurant. You look at it, you get asked questions about it, you give it back. This is a toolkit that we work into clinic flow in a very similar way. When the MA takes the mother into the examining room, she says, here's what we'd like you to look at today. Let us know what questions you have, and your provider will be talking with you about it. And then the provider needs to talk about it. That's the next step. And when we support clinics to utilize open-ended questions and help mothers explore their concerns, it saves time in counseling because you're counseling about the mother's concerns, not about the 18 other things that other families might have concerns about. So prenatal education is, we think, is a priority, and we found great success in improving exclusive breastfeeding rates just by really hammering on that one first. Then step 4 and step 7 are particularly important to get to next. Auditing, finding out where you really are with skin to skin. Some of our hospitals said, oh yeah, we do skin to skin. Interrupted. We do skin to skin when it's convenient for us and we don't call off a lot of staff. We do skin on the elective sections. So really, what are we doing with skin to skin with everybody? And then that will support breastfeeding in the first hour. So when skin to skin happens, we just see the whole rest of the hospital stay being a one that is more supportive of breastfeeding, and the mothers, they get such a boost of confidence. Wow, look at my baby. He's so smart. He's looking in my eyes. And that carries her on a baby moon, like a honeymoon. It carries her like a baby moon through her hospital stay. And then rooming in is the natural other side of skin to skin. You get them together to begin with, and you keep them together for the whole hospital stay. There's a hospital in New York that everybody said, yes, we're rooming in, yes, we're rooming in, yes, we're rooming in, and the policy was rooming in, and the nurse manager shared that she just really needed some data with her nurses, that talking about how wonderful it was and bonding and appealing to that elephant, the emotional side of us, wasn't working for her. So she had a quick and dirty QI project where they noted the location of the baby at every time vitals were taken. So it was a safety QI project, right? Baby's vitals. We're going to check the baby's vitals. Oh, and by the way, fill out this column that has the location. And sure enough, instead of being anywhere near the 23 out of 24 hours a day, there were big gaps in times that the mothers and babies were actually together. And then she could take that information and say, well, why are our mothers and babies so impaired that they can't be together? It's us that's taking them apart. There must be a good medical reason for us to do this. So her logic, the way she shaped the path, was a little bit subterfuge, right? But sometimes it takes that, being a little bit going around the back door kind of thing. So finding out where we really are with rooming in, and then looking at what are the things that we can do to improve these practices. And then after that, we find that hospitals do best if then they really dive into exclusive breast milk feeding and the alternative feeding devices. And they tend to go well together. Okay, we need to, you came in as a breastfeeding mother, and now there is a need for formula, either medically indicated or because mother has requested it. So we need to explore what are the concerns. If it's the mother request, we need to address her concerns, and then we need to appropriately supplement if we have done that, and then we have to document that we've done that exploration and assessment and education, and it's still maternal request. And if we have a medical indication, some mothers are really disappointed that their exclusive breastfeeding plan isn't going to happen because there's a medical indication. So both of those things are tied into step 6 and step 9, because when you need to supplement, whether it's mother's own milk, donor milk, or formula, we need to go through these very similar processes. So the supplementation I put below that because It's not specifically a step, it is a goal to reduce supplementation. So the main policy that you have will have very little in it about supplementation. So it's a tangential policy that we find our hospitals writing in addition to their main policy. And then supplementation is with what? What are we going to supplement with? Mother's own milk, donor milk. In some hospitals they use hydrolyzed formulas before they use formulas. So your hospital needs to decide with what, how much, different on day 1, day 2, day 3 of life, and with what method. How are we going to deliver that? Spoons, cups, syringes, how are we going to deliver that? If maternal choice is there for bottle, then how we document that. So supplementation policy is somewhat separate from that one. And then our clinical competencies really come around step 5 and step 8. The showing mothers how to breastfeed, helping them all learn hand expression, and then supporting lactation during supplementation are all in step 5. And this we find is really well done when we have super users, when we have those CLEs or CLCs or charge nurses or CNSs or lactation consultants who are the ones who are the most competent, and then their skills are validated, then they can validate the skills of the next group and the next group and the next group. So part of the work plan is creating a way to roll out the 5 hours of clinical competencies. And as I said, this is a little later after we've done some of the other groundwork first. And feeding on demand and teaching feeding cues ties really well into teaching mothers about normal breastfeeding, teaching her about normal baby behavior. And baby behavior coming out of UC Davis is just fantastic work. And in California, for sure, our WICs are all being trained in baby behavior, and we are one of the groups that's trying to figure out how to bring that body of knowledge that Jane and UC Davis have created, move it from the WIC world into the hospital-based world. What is normal infant behavior? Not just feeding cues, but also satiation cues, and nighttime and fussy and calming fussy babies, all of that. So Marianne had elephants earlier. My elephant's representing a little different topic here. The elephant in the middle of the room is often purchasing formula. And I'm so glad that it went well for Karen Moore and her team. We find that it is a challenge and stumbling area in many, many ways. So I want to get it right out right front. Baby Friendly's work plan, which we're going to go through after lunch together in small groups, and it's not so much on the 4D pathway here, but they recommend that you start your formula contract and negotiations out here in designation. And we've found that it takes hospitals many, many, many months, sometimes years, to get from the point of, yes, we want to do this, and we are committed, and we will be purchasing formula, to actually having all the little pieces in place to actually be purchasing and have receipts that can document that purchase. So we in Breastfeed LA, we recommend that when people are early in development, that they begin this process. And the process is figuring out what's the fair market value. You buy stuff for your unit. You consume, your patients consume, your patients consume medications, they consume food, they consume things that are disposables like pads, and many other supplies that we end up purchasing in hospital. And you are paying for those on your unit, and you're paying for them at some sort of discount off of retail. And that discount that is consistent in your department, your average discount, is considered your fair market value. So if Tylenol is, I'm just going to use a number because it's round, is $1, but you only pay 10 cents for it, you have a 90% discount. And if for many of your items you have some number, 80, 90, 70, 80, 90% discount is very, very typical. How many of you are involved in a hospital that is a purchasing group? You're not just purchasing on your own. Okay? So this is part of the challenge, because the purchasing group is the one that's setting that price that you're going to pay, but you're doing the work to find out what's fair market value in your community, in your hospital, and the two of you need to work together to get a price that's going to be fair market value and meet Baby Friendly's requirements and be ethical. We should be paying for things that we use for our patients. Be ethical, and then also be one that's acceptable to the corporation, to the organization. And it takes time to have those conversations and make it work. Karen?
And indeed, the money part was not the issue, but let me tell you, I'm in a very small community and the relationships were an issue. Those formula reps had been 20 years in their career. They had a relationship with all those managers, with the hospital, with the physicians, and that was difficult.
Yes, the formula companies representatives,
They're no longer welcome.
there you go. Formula representatives are very, very skillful salespeople. They really are, and they have wonderful, from their point of view, wonderful internal training, and they are our competition. The formula companies are our competition. So when we talk about the elephant in the room, I think that's another thing to get out on the table right away. It is not in their interest for us to be successful, and the relationships are part of how they keep their market share, how they keep their market share, and it is a time-consuming process. So we recommend, this is a little different than baby friendly, we recommend that while in development that you calculate that fair market value. There's a worksheet in the budget section of Baby Friendly's toolkit. You've got it. Just pull it out and work through it and talk to other people in this community about how they've done it already. And then begin the contract negotiations. And by that I don't mean that the nurse manager talks to the formula company, but the nurse manager first needs to talk to her purchasing people. And to get the formula guys to not come in her unit as well as part of that. But that contract negotiation, some of that is about just getting the purchasing people to understand our concept, our concerns, and what our ethics are. In Kaiser, this part became moot when the ethics committee said, that's it, we're going to purchase formula starting January 1, 2008. They were in the old method. They would have been, if it was today, they would have been in development still. And they were purchasing formula. And we all said, oh my God, we thought we were supposed to wait till last for that. But what was really exciting is that January 1, they started paying for formula. In March, the nurse managers, they call them DAs, department administrators, got their budgetary reports for expenditures in January and February. And in April, the breastfeeding rates were much, much higher, so that the formula purchasing money was much, much lower. So having a budgetary side to this is not all bad by any means. And then in dissemination, choose that timeline. When is it that we want to be green for purchasing formula, green light for purchasing formula? And know that when you come up to your on-site survey, you have to show at least 3 months of proof of payment, of receipts, not just invoices. We had a hospital that was there. They were all ready for their on-site survey, and they had orders. They had purchase orders for formula, but they had no documentation of receipts because the formula companies didn't send it to them. It's in their interest for us to be delayed and fail. So we have to get on top of this and be ahead of it. We like to keep score in life everywhere. So this is really tiny print, not meant to show you that, but take a look, red, green, and yellow. Green, this was in July, and the 3 hospitals with the most green, one of them just had their on-site survey week before last week. One is scheduled, but the other 2 are scheduled for October. So we update it every month. This is a couple months old. But we find in our collaborative, it works well to help everyone see where other people are. They can, it's part of the conversation between hospitals. How did you get that one done? We're struggling with that. It also helps everybody stay focused. Yes, we need to get to green. Oh, good, you can make that one green now. That's one of the things that happens in our meetings. And we aggregate the data as well, or label it in a way that's good there. Okay, we're going to watch a video at this point. So I'm going to switch a little bit here to how do we change these behaviors. We've talked a lot about the work plan itself and the order in which I suggest, so that's the path. Go. And we'll watch here.
What you're about to see is real. Real kids doing real things. Just thought you should know. My name's Hiram Grant, and I was there for the whole thing. So here's a question. What does it take to get people to change? And I'm not talking about their socks and underwear, but change behavior, especially when it's hard. For example, every year close to 100,000 people die from hospital-acquired infections. That means people got sick at the hospital. And it turns out one of the main culprits is hand hygiene. That means just getting people to wash their hands could save lives. So my crack research team decided to conduct an experiment to see if we could change something as difficult as hand washing habits, only with the toughest subjects of all, kids. So here's what we did. We took 80 munchkins and put them into groups. First, we gave them a challenging puzzle to put together. You know, kind of like the projects you adults are always busy with. Then, we gave the kids a tempting distraction.
Hey guys, I got the cupcakes for you right here. They're delicious. So right over here.
Once I see that you guys have put the whole puzzle together correctly, I'll raise my flag, just like this, and then I'll blow my whistle. Okay? And when I do that, you guys can all go and get your cupcake. So what would it take to get these kids to wash their hands? How about a good reason? So one thing you guys should know, there was a sick kid in here playing with the puzzle pieces. He had a runny nose and coughed a lot, so there's probably a lot of germs on it. There's hand sanitizer over there on the table that you can use to wash up. Okay, which will win out? Delicious frosted cupcakes or the fear of the typhoid toddler? Let's watch. They finished their task, and look, if the threat of one sick kid wasn't enough, just look at all the new germs. So, good reasons to wash? What do you think they'll do? So that was a colossal failure. Now what? Well, at this point, most adults would quit. That's why you just keep changing the year on those New Year's resolutions. With the next group of kids, I changed the environment by moving the hand sanitizer closer, and then put up a visual cue. This ought to make hand washing easier and more obvious, right? And in the end, the motivation to not get sick plus changing the environment didn't influence a single kid. Yikes. Next, I increased their ability, which is another source of influence. I had them all complete what is known as deliberate practice, or training, to increase their familiarity with good hand hygiene. Will adding another source of influence get these hand-washing offenders to wash up? Done. And... well, now we're seeing some better results. We're combining 3 different sources of influence, and some of the kids are actually washing their hands. It looks like we're on the right track. So next, I added another source of influence, social influence. What if somebody spoke up and said something? What would happen if their bosses were in the room with them? Here come the cupcakes. And there goes the flag. Will they wash? No! Look at them pouncing on those cupcakes like a pack of ravenous hyenas. But it's not too late, because something important happens. At just the critical moment, a peer, not even one of the bosses, speaks up. Wash your hands. Watch the effect. Success at last! So social motivation obviously made a difference. But was it the only thing that mattered? What about our other sources of influence? Here's what my kids had to say.
I was walking over to get my cupcake, but then someone said, wash your hands, because this boy has the sniffles.
So what's the point? We often underwhelm overwhelming problems. We try a couple of things, and when they don't work, we give up. But my dad and his colleagues discovered the secret to overcoming tough problems. You need to combine at least 4, preferably more, sources of influence. And it doesn't matter if you try it with kids, or hospitals, at the office, or even at home. If you use 4 or more sources of influence, your chances for success go up 10 times. 10 times! So there it is. The key to changing almost anything is to marshal the power of at least 4 or more sources of influence, but preferably all 6. And heaven knows, we need it.
That's it. Escape. Work in your teams on the work plan document that Baby Friendly USA provides, and then we're going to talk more about the Joint Commission data collection requirement and the Baby Friendly data collection requirements. So we left with the cute video that had the children explaining to us that change is hard, right? And may I? Sorry, change that? No? Or yeah, go ahead. And so where this came from is from the influencer model. You can Google that and find the book. The idea here is that really what we want are measurable results. We want breastfeeding to increase, right? How do we do that? We have to change vital behaviors of our providers, our staff, and our mothers. And how do we do that is by leveraging more than 4 sources of influence given this model. So this is the whole grid, and it's divided into categories, this being personal, social, and structural. And I'm going to use hand expression as the practice change. How many of you are comfortable and confident teaching mothers hand expression? Almost everybody in this room. How many of you would say that your staff, at least 80% of them, are comfortable and confident teaching mothers hand expression? Good, I chose a good topic. We got one expert in the room. She'll help me. So using hand expression as a model, first of all, when we talk about the reasons why to teach something, we want to find the personal motivation. So remember, it was the germs that they talked about with the little kids. Oh, there was a sick kid in here. Well, with nurses, we usually, and healthcare providers in general, we usually talk about the why to and the how to. The why strikes somehow a chord within us of why this is a good practice to teach. So you tell me, why teach hand expression?
Your hands are always available.
Hands are always available. Moms can't lose them. They're easy to wash. You don't lose any parts. Like if you've got a pump and suddenly you left the something at home. No, it's all here. What else? Yes, we have disasters that do happen, and electricity is not always available. What else?
Helps increase breast milk supply.
It increases milk supply, the tactile nature of that, and the immediate feedback from the mom. It's not even biofeedback, it's manual feedback. She sees the milk, and it increases.
It increases the mother's confidence.
Confidence.
She has milk.
Absolutely. So these are a list of reasons from the core curriculum, but you guys have pretty much touched those. Oh, the top one, we can supplement with mom's own milk as well if we do hand expression. So lots of good reasons why. So when we're training staff, we touch on their personal motivation. Down here in the corner, I'm directing you to which source of the 6 sources of influence it is. It's number 1. We make the undesirable desirable. Somehow it's undesirable to put your hands on some other woman's breasts, which always is amazing to me because it's always okay to do fundal massages and pericare and all kinds of other things with our hands, but somehow we have this cultural issue in our country that we don't put our hands on other people's breasts. So it's an undesirable thing. So we have to make it desirable. So we make it desirable by talking about all the reasons that this is an important practice and that the evidence supports it. Number 1 then, why to? Number 2, how to? So this is an example of one of the DVDs that's out there that we use to train staff and providers how to teach hand expression. So if you haven't seen it before, if you Google Dr. Jane Morton hand expression, it'll take you to an free online video that you can look at. It's also on this DVD with 4 other subjects. It's an excellent DVD worth investing in for staff and provider training.
Oh, it's not expensive at all.
Yes.
Loaded on Get Well Network. It's prescribed for all of our patients.
Oh, right. So for the tape, it's easy. You've loaded on your Get Well Network. It's not very expensive either in the big scheme of things,
No,
for sure.
Very, very
Very affordable. So this is part where we're over-investing in skill building. We're helping staff become more comfortable by providing them with a training video that's very specific and positive and works well. There are others out there, and I encourage you to explore sharing with your staff what does hand expression look like when you have a mature milk supply, which is very different than this video, which is a colostral phase, and some engorged breasts. And so then, in our third area, so now we're talking about leveraging a third source of, let me back up. When we, I don't remember how to back up so well, when we do this, we do the why to the how to, and we do this all the time in healthcare education. We say, this is why we need to do it, this is how we need to do it, and we walk away. And nothing changes. Our practices don't change. So we have to leverage more. So using this model, let's look at some other things we can leverage with respect to this specific example of hand expression. In harnessing the peer pressure, we can find those champions. Almost everybody in the room raised their hand today. In your own facilities, you will find many people who are comfortable and confident. They're your people to be your leaders, be your preceptors, be your champions, be your super users, whatever title fits. Give them a title and have them available to their peers. And like in many, many things in healthcare, when we watch one, then we do it, then we turn and we teach it. So you encourage more and more people to, and support more and more people to become leaders. And then just one of the things that I see a lot of our hospitals doing is making the basics of baby-friendly issues part of the SBAR or the report that's given from one nurse to the other. So what's going on with exclusive breastfeeding with this mother is one of the topics, along with pain and temperature and fatigue and hydration and the other things that are communicated during shift change. Breastfeeding is communicated as well. And when a couple of our hospitals added hand expression to that as well, I taught her hand expression, and she had just glistening on both breasts. Milk really wasn't flowing, and I told her to try this every time the baby was after the baby was at the breast. So every kind of a very frequent kind of instruction. So that's what I did. And then I tell the nurse who's following me that's what I did, and then she knows what to build upon and can continue to reinforce for that mother, help her get from just glistening to dribs and drabs to some milk that can be shown. So talking to each other and rounding when charge nurses and managers are rounding, to be asking the moms what's going on, to round with staff so that they can listen to how the staff are teaching hand expression. So peer pressure, having nurses help nurses be better nurses. And then Batman and Robin, two of my favorite buddies, finding strength in numbers, looking around, buddying people up. Again, using that term, identifying the super users. So how can we increase the ability of the social networks that are going on? So to be thinking about how we can increase the social network. And then if we go to the structural ability, what can we do to change the environment? Well, the policy is a structure. And the policy should include that hand expression is discussed prenatally and that it's discussed postpartumly. Many, many, many of our hospitals are teaching hand expression in labor when they have a mom who's teachable in labor. So if she's got a putsy labor and you teach hand expression, gee, it might even help that labor along. It certainly boosts her confidence to see, wow, I'm pregnant and I have milk. So both prenatal and postpartum in-hospital policy can support teaching hand expression. And then on the practical side with the mom, ensuring privacy. If it's during cuddle time, that's kind of easy because you've already asked the visitors to leave. But if it's not officially cuddle time and it's time to do this education with mom and dad, then it's important to ask the other family members and visitors and Uncle Joe and Cousin Charlie to go have a cup of coffee in the cafeteria right now. Some of our hospitals have double and even quad rooms, so utilizing the curtains and ensuring privacy in that way, helping the mom have the privacy she needs. Using breast models to teach. Some of us are so comfortable we will model on our own breasts, right? But if we have a cute little stuffed breast model that's bright colors, it can really, especially with physicians, help to decrease the anxiety about learning this skill. It's just another skill. So we use breast models a lot. And then posting your rates. Today, 45% of our mothers said they were taught hand expression. we are all going to work to increase that over the next 2 weeks. It's going to be our theme. We're all going to work on it, and then we're going to post as our rates increase, because they will. So changing the structural ability of everyone. And then I think this is last. It's called number 5 on their model, but I think it's last, and that's demanding accountability. You don't do that first. First you make sure everybody feels comfortable and confident, and you put as much energy into the other systems that you can. But then there comes a time where you got to do this, ladies and gentlemen. We are all teaching all mothers how to all breastfeeding mothers how to hand express. And we can help along the way by examining competencies, which is required in Baby Friendly. It's a tool that can work for us. And then we can audit the mothers and listen to the mothers. So you can take this model with any practice step, any set of behaviors you want to change, and give thought to what are the activities you can do in each of these 6 areas, because if you get 4 or more, your success increases by 10 times. And the author of this book has a lot of different examples from a lot of different industries. This is an example we've found here. We've also used this one with pacifiers too. Can be good. So I'm going to stop on this presentation right now, and we're going to pass out to the hospital teams the work plans. I'm going to ask you to open the document and start to get your head around it. And your assignment is to see if there's pieces that you want to own. As you look at the work plan, yes, I volunteer for that piece. That's your assignment. And of course, you'll probably talk about who's not in the room today that you want to own that other piece, and that's appropriate tactics. If you already are down the baby-friendly pathway a bit, and this is not your beginning, then look to the work plan to see, well, what do we need to dust off and use again? We probably need to revisit our work plan. You're not the party pathway. They're a team. I like it. Here's one that needs a team, maybe 2. Yeah. I'm sorry.